parent comes in worried about a photo with a white reflex.
So I think it's so important that every parent can know the glow, meaning that they understand that if there's leukocoria in a photo, that child really should come to evaluation. And so again, I'm thrilled when parents know the glow and they bring their kiddos in.
What is retinoblastoma? How does it form?
As you know, retinoblastoma is a cancer, a malignancy that forms in the eyes, one or both, of young children. It's formed by a genetic alteration in the retinoblastoma tumor suppressor gene. So that is a gene that stops cells from growing. It's a stop sign gene.
And that's honestly what I tell parents. I mean, the snapshot I get in the office, which is very different than what you get.
Yeah.
I mean, I might examine the patient 15 minutes.
Yeah.
It's
very
15 minutes compared
right.
to them living with the child. So I do always tell parents to trust their gut, and if they're concerned, especially over something like this.
Yes.
Today's guest is someone I admire deeply for her impact in the field of pediatric oncology. She is an internationally recognized expert and researcher who's helped reshape and diagnose how we treat retinoblastoma. Dr. Jessie Berry is the Director of Ocular Oncology at Children's Hospital Los Angeles and a professor at the USC Roski Eye Institute and one of the world's leading experts in retinoblastoma. It's a very rare eye cancer in children. We're going to really dive deep into today. Dr. Berry has made headlines for her pioneering, groundbreaking liquid biopsy technique that allows doctors to analyze tumor DNA from the eye without surgery. And her work is helping to diagnose cancer earlier, personalize the treatment, and ultimately save not just children's eyes, but their lives. Jessie, we're so glad you're here today. Thank you for joining us.
Thank you for having me. I'm thrilled to be here.
So you and I both see this all the time. Let's just get into it. A parent comes in worried about a photo with a white reflex. And I know in my practice as a pediatric ophthalmologist, it's such a common question, and it's not necessarily always straightforward to reassure them or decide when it needs urgent workup. So how do you approach these conversations in clinic?
Yeah. Such a great question and such an important question. So I'm always thrilled when parents recognize the leukocoria or recognize the glow in a photo and bring their child in to be evaluated. Oftentimes they see my pediatric ophthalmology colleagues first, and they get to me maybe if the parent is extra persistent. And I actually tell them that I have a really striking photo of my completely normal daughter who's looking in a certain direction and has really striking leukocoria or the white reflex in that photo. And that photos in and of themselves are about raising awareness, letting parents know when to bring their children in. But once they're in the ophthalmology office, we have so many better tools to identify what's going on in the eye, and that we don't have to rely any longer on the photos that they have on their iPhone.
Because I bet there's probably some part of it, even when you do your full eye exam, that they say, but this picture still has the white reflex. And you've started this campaign. I forget what is it?
Yeah, well, I didn't start it, but I work with the team, Know the Glow.
Yes,
and
I love
so,
that.
Yeah, it's my mentor coined the term, and it's so great. So I think it's so important that every parent can know the glow, meaning that they understand that if there's leukocoria in a photo, not necessarily just once, but repeated leukocoria, that child really should come to evaluation. And so again, I'm thrilled when parents know the glow and they bring their kiddos in. I often get emails or parents will reach out to me and say, I saw the glow, here's the picture. I went to an eye doctor. The eye doctor did a full exam. They say my child is completely normal, but I don't believe it. I'm sure they have retinoblastoma.
Yes.
You know, can I come see you? And really in those cases, I reassure them that if they've had a fully normal eye exam by someone who has dilated their eye and looked all around, they can rest assured. In my practice, of course, I have access to a B-scan ultrasound, which takes, an image in the back of the eye. So for anyone who comes to me, I'm always going to ultrasound them. I often will take pictures of one or both eyes and say, look, they look the same. Here are the ultrasounds. They're very normal. But trying to build that trust sometimes can take some time and take some additional imaging.
Well, and I think you and I are both moms. And I know personally, especially with our medical experience, like if something happens to my child, my mind already goes to the worst case scenario typically.
That's right.
And so I understand where parents are coming from. But is it enough? Just they might feel like, well, we saw the pediatric ophthalmologist or we saw an optometrist.
Right.
They dilated the eyes, but we're not sure
Yeah.
if it's enough. How do you counsel them in that way?
Well, to be honest, it is hard because almost all of my patients who all have retinoblastoma were told by another doctor that their eye was fine.
Really?
Almost all of them.
They're not referred from the...
Right. And so it is a really difficult situation,
Yes.
and I'm glad parents trust their gut, and I'm glad they push.
Yes.
When they're in the office of an ophthalmologist and the ophthalmologist has seen them, has put the drops in to dilate them, again, sometimes put the probe on the eye to do the ultrasound, I really feel confident about reassuring them that they had a good workup. They were checked for glasses, the glasses prescription was the same, all of these good things. If somebody was not seen by an eye care professional, then I really recommend that they are because, in a pediatric office, it can be very difficult to see leukocoria well. Very, very difficult. They don't have any of the tools that we have for that. And if parents are seeing it, they'll say, oh, every time I bathe my daughter, I notice the leukocoria. Well, they're probably bathing their daughter in a low light condition. The pupil is dilating and they're noticing something. And so I think it's completely fine to do an ultrasound, to send patients to eye care providers, and to really get a full workup in those situations. In fact, if I could say anything to my colleagues who don't do ophthalmology, it's if a parent has complained once or especially twice about leukocoria, just refer them.
Right.
Just refer them.
I think sometimes people worry, oh, well, I don't want to send a patient unnecessarily or give them extra anxiety, but they're already anxious.
They're already anxious.
Yeah. I mean, there are, of course, I see in my office a lot of different reasons to cause leukocoria.
Yep.
You can get it from misalignment of your eyes or uncorrected refractive error
That's
or
correct.
astigmatism. But when they're in your office, you're going through all the other things. Hopefully, if they've gotten from me, and I say, well, I don't see the astigmatism, I don't see the strabismus, but I'm also not doing an ultrasound in the office.
Right.
I'm usually not doing a very extensive peripheral exam. I'm not.
That's right.
Using
It's a different specialty,
depressor.
really.
It's a totally different area. But I will always refer if I feel like I'm not getting a good view. And there's sometimes patients that we just don't get a good examination, and for the most part, then it's better to send.
That's right. And when the patients come to me, I need to do a really detailed evaluation. If a child has any mass in the back of the retina, even if it's not retinoblastoma, you still need a really detailed evaluation. So not only do I have tons of equipment, I put my kiddos to sleep. So my patients go to sleep, they have safe anesthesia done by a pediatric anesthesiologist, so then I can do my job without a kid screaming, a parent being anxious because their baby is screaming, without me being kicked by a kid, Like they get to go to sleep, they are comfortable and safe, and then I do everything I need to do to evaluate what's going on with the eye.
And when I trained in New York, almost 25 years ago, Dave Abramson was doing the same thing.
Right.
And I think he was getting a lot of flack for it initially because there was a lot of anesthesia for these exams. But I could not imagine getting as good of an examination in my office when they're awake and they're sitting on the parent's lap and sometimes the parent doesn't want to hold them. I'm getting a look just of the posterior pole.
Yep, that's
essentially.
exactly right.
Maybe some glimpses if they're moving all around of something else, but otherwise just of the center part of the retina, and retinoblastoma could be in the periphery.
That's exactly right.
And we can miss it. So I didn't realize that you also put them to sleep. And I think that just seems to be the most effective way.
Yeah, I think for most of us, it's standard now. Thankfully, anesthesia in kids, especially when done by somebody who is used to putting children to sleep, is very safe. It's very controlled. It actually makes the exam a lot faster because we're not fighting. In clinic, I probably see 30% of the eye, right? And I'm seeing that, I'm moving, the kid's moving, everyone's moving. When they're asleep, I can see 100% of the eye. I can actually even do, special anterior UBM imaging so I can evaluate the area behind the iris and make sure the ciliary body is okay. All of this is really necessary. And so, I tell parents, if I think that there's retinoblastoma there, this has to be done because this is a cancer that, if not taken care of and treated, is not only blinding and a risk to the eye, but is a risk to the life. So yes, there's always some risk with things, including with anesthesia, but if we think it's retinoblastoma, that has risk too, and it needs to be evaluated.
Okay, so I just realized we started off talking about retinoblastoma, and I think if people are looking for it, they know what it is. But let's just start from the basics.
Yeah.
What is retinoblastoma? How does it form? Talk about the genetic mutation and all of that.
Yeah, absolutely. So as you know, retinoblastoma is a cancer, a malignancy that forms in the eyes, one or both, of young children. Most often diagnosed under 2 years of age, almost always by 5 or 7 years of age, although I had an adult case this year, so adult cases do happen. Very rare, but they do happen. They tend to be sort of a reactivated lesion from a originally benign tumor, but it is a cancer, and it's formed by a genetic alteration in the retinoblastoma tumor suppressor gene. So that is a gene that stops cells from growing. It's a stop sign gene, and if it's not working, it means the cells can just grow unchecked and form these tumors. Some of the kids only have one tumor in one eye. Other kids have this alteration in the gene in their body, and then they get multiple tumors in both eyes. And that also changes the way we approach how we treat them, how we work them up, and how we follow them through life.
So when you are looking at a child in your office and you're doing the examination, tell me about just the workup genetically to be able to determine what's the risk to other siblings. Let's start with the genes, because then the parents are obviously going to be, if they have other siblings, they're going to be worried about their other children as well.
Right, exactly. So once we've diagnosed a child with retinoblastoma, we will automatically do genetic testing. And at our hospital, this is unique and evolving, and I know we'll talk about it later, but we actually do genetic testing 2 ways. So generally, people test the blood. And in the blood, they're looking to see whether the alteration that caused the cancer is present in the body. Now, if I'm looking at a child and the child has cancer in both eyes, I already know they have the alteration. Yeah. So I might not know exactly which alteration they have, but I know that that gene is not working, and it's not working in their entire body. So I can give the parents that information right away and tell them we'll do the blood test to confirm exactly which alteration it is or which mutation is in the gene. If the child only has cancer in one eye, I don't know. I can't tell by looking generally. Yeah. And so I need this test to tell us. What we do now, or what we're actually starting to do, is to actually take the fluid from the eye. We'll talk about this a little later, I presume, but the fluid from the eye acts like a biopsy. We can identify the mutation in that fluid. The fluid's going to have it. And then we can specifically test the blood for that alteration. So it makes the test a little faster, a little easier. And then actually, with very, very high sensitivity, you know if that mutation is in the blood. So it improves the overall sensitivity or the correctness of the test.
So do you screen then all siblings, even if it's just in one eye versus two?
So it takes about 2 or 3 weeks for that alteration, for that test to come back. So generally, I'll ask, are there other siblings? Are the other siblings okay? If there's a younger sibling, let's say I'm seeing a 2-year-old patient and they have a new baby at home, often I'll say, you know what, while we're waiting for this test, why don't you just take new baby to have somebody look at them. But usually I just wait for the results of the test. If the results are negative, then there's a small chance that the test could be wrong. No test is perfect, but it's actually a pretty good test. Greater than 98% of the time it's correct. Nothing else is needed. If the test is positive, then there's all sorts of things that are needed. So even if the test is positive, meaning that the alteration is present in the gene, the parents are usually fine. Usually it's a new mutation that came together as the baby was made, but we still like to test them. And then if the parents are positive, we test other kids.
Okay.
Does that make sense?
Yes.
Yeah. And then if the child has the mutation, they really have to be followed throughout life because they are at risk for other tumors in the eyes and other tumors in other parts of their body throughout life.
Okay. And that makes sense. And then you're also saving, instead of screening every single child, because it doesn't make sense to screen a 10-year-old, because obviously it would have presented more than likely
in general.
by then.
Yep, exactly.
So even getting back to the basics of the white reflex.
Yeah.
Let's just talk about what it is that people are seeing when they see that white reflex in the camera flash.
Yeah.
What's causing it?
So at least for retinoblastoma, so generally when you, people used to do these red eye filters, right? Because the light goes into the eye and it bounces off the red retina. The retina is red, at least in part, because of the blood vessels that are going into the retina. And so you'd see this red flashback. If there's something that's preventing that, the reflex can look yellow or white. So in retinoblastoma, it's actually the light bouncing off the tumor, and the tumor is white. It's one of the things I found most fascinating about this field is I can look into the eye of a child, I can see cancer, and then I can see cancer go away. It's amazing. There are other things, as you mentioned, that can cause this, including just a difference in the amount of refractive error or glasses
that's
that
what
a child
I see
needs.
most commonly.
Yeah.
I mean, that's really, it's going to be the most common things that I see is one eye is a -8, the other one's not.
Yep.
You get the leukocoria, the white reflex.
Absolutely.
Or pediatric cataract, of course, is another one that's quite not common.
Yeah, but
that
seen.
ends up in my doorstep.
That's right. Yeah, pediatric cataract. And then, I also see things that are various congenital anomalies with the retina, like persistent fetal vasculature or Coates disease, or trauma that's caused a retinal detachment, all sorts of things that can mimic retinoblastoma.
I had a fever patient that caused that. I was concerned, but didn't quite look like it.
Yep.
So a lot of
fever is a
things.
common one, and fever sometimes, if it's bad, it can actually mimic retinoblastoma.
It
you can get a
definitely
mass,
did.
and there's calcification, and it can be scary.
And it was scary in this particular patient because they were from the Big Island, so they were already flying in
to see you,
to see me. And I said, I really am nervous about this because it wasn't bilateral, it was unilateral. So I sent them to LA to get have it checked. This was before you were here, so I sent him to Tom.
He was good at this as well, but and I'm grateful to him for all the work he did in this field. But what we do now, honestly, is we take the fluid, we take the aqueous humor, and it gives people a lot of relief. Like you said, even when a doctor tells a parent who's seen this in the picture, everything's okay, there's still anxiety. Same thing, a doctor can look in the eye and say, I don't think this is retinoblastoma, but let's watch. That leaves a lot of anxiety. So it's kind of nice to have a test. And then there's a piece of paper that says this is or is not consistent with cancer. So
are there things at home, little simple home tests or checks that parents can do?
I probably scare every new mom that I run into. I'm sure my husband is like horrified, like, please stop talking about cancer to this new mom. But I think it's so important because so many moms don't know about it, or dads. And again, the parents are the ones that notice the glow so often. And like you said, it doesn't just mean cancer. It could mean other things in the eye. But I just let them know to pay attention to the eye, pay attention to if the eyes are straight. Obviously, they don't need to be straight right away, but if there's a persistent deviation, especially in one eye, and to really pay attention to that reflex in the eye. The other thing is some of the filters that are in our phones are really good at correcting the glow, even though you don't want them to correct the glow. And so sometimes video, actually, if you take a video of your child, you'll see it more. And I have one mom, she's incredible. She took tons of pictures and it was fine, but she saw it on the video. And, as you remark about retinoblastoma being in the periphery, I have a retinoblastoma clinic, so I have my patients a little bit pre-screened. So they came in and he was a little bit older and they had pictures of the posterior polar, the back of the retina. Totally fine. So I looked at that. She's complaining about, I saw leukocoria in pictures, and automatically I thought, this is going to be one of those pseudoleucocorias. It's going to be totally fine. She showed me the video and you could only see it when he looked down, and that's where the tumor was. Yeah.
That's where it was.
Yeah. So, mom was amazing and absolutely diagnosed her kid and got him to care, I think, far sooner than many.
Right, because that's a difficult location.
Really difficult. Yeah. And she said the same thing. I didn't notice it in any pictures. I only noticed it in the video.
And that's honestly what I tell parents. I mean, the snapshot I get in the office, which is very different than what you get.
Yeah.
I might examine the patient 15 minutes.
Yeah.
It's very 15 minutes
compared
to them living with the child. So I do always tell parents to trust their gut, and if they're concerned, especially over something like this.
Yes. And if you see it worsening, changing, more persistent, these are all things we'd want to know.
So once you have a patient that you suspect retinoblastoma, just talk us through the entire process. You kind of started about doing the anesthesia, but what tests are you doing? Just the process.
The whole process?
Yes.
So if I have a kiddo in my clinic and I think it's retinoblastoma, the world kind of stops, and my whole team knows this. And, we have a big team focused on the care of kids with retinoblastoma. Those kids need to get to the OR fast. Yes. This isn't like, I'll see you in 2-3 weeks. Right. This is, my team is calling their insurance to get insurance authorization emergently so that we can get the patient to the OR. Our goal is within days, if possible, definitely within a week. These kids also need an MRI. So they need an MRI to evaluate the brain to make sure there's no spread into the brain or to the optic nerve that connects the eye to the brain. And then in my OR, all of my patients are dilated. I know all my parents say, please no more drops. I'm like, nope, they have to be dilated. I have to see the back of the eye. And then I take pictures of the back of the eye. I do ultrasound imaging of the front and the back of the eye. I measure the tumor. If there's fluid under the retina or seeding, I identify and evaluate that. And then I also do a special kind of imaging, OCT imaging, which looks at the layers in the retina. And we've identified tumors using OCT that are too small for me to even see. So they're so tiny, they're only visible on OCT. It hasn't disrupted the architecture of the retina yet, so we can't even see it. And you can treat those with a couple of spots of laser. So it's pretty astounding. And then sometimes I put dye in the veins and do a fluorescein angiography to show me the vessels in the eye, if there's leakage, if there's any leakage in the iris to suggest neovascularization. And that's sort of my initial imaging workup. Okay. And then almost all of my patients then get the liquid biopsy at diagnosis.
And then how do you decide
what's next?
What's next,
yeah.
Right? I know based on the MRI. I mean, back when I was training, it was still CT, and the data was just coming out
for
that
MRI.
CAT scans can cause additional cancers in these patients that are already
predisposed.
susceptible. They're predisposed, so we need to switch over to MRI. But that was literally right when I was in fellowship that change was occurring.
So thankfully, we can get the MRI pretty quickly here. Oftentimes, it's even done before my exam under anesthesia, so that the whole package is ready for me to go out with the families. Not always. Sometimes it's done right after, but more or less it's there. And then there are a lot of factors that determine treatment. So we won't have the genetic results right away. Yeah. We're making decisions based on the clinical features and the age of the patient, whether the cancer is in one or both eyes, how much of the eye is intact. Like, has the eye been completely destroyed by tumor? Is it in the front of the eye? Is the pressure high? And then what do we think the vision may or may not be? We can't always tell, to be honest, but if you see a tumor that has destroyed the entire retina and there's high pressure in the eye or tumor in the front of the eye, you have a pretty good idea that unfortunately this is an eye that's not going to see well, but sometimes we can't tell for sure.
And then
then there's this is an area of hot debate in the retinoblastoma community. At our center, we still do systemic chemotherapy for children that have disease in both eyes. This is hotly debated. There are some places that will not do systemic chemotherapy at all. The reason we do systemic chemotherapy is that it's low dose, it's very well tolerated, and it's one treatment that goes to both eyes. We follow these kids, and ultimately they often are going to need laser or injections or freezing therapy to help consolidate the tumor, but it can be very effective. The cure rates for retinoblastoma in the United States, thankfully, are very, very high. And so, for most cancers, you're talking about life of the child.
Yes.
Thankfully, because we get these kids early, when the tumor is still in the eye, most of the time we're talking about saving the eye and saving the vision. But our entire practice and any treatment decisions we make revolve around, is it safe to try to save this eye? Will it put the child's life at risk by doing so? If you don't do systemic chemotherapy, the other tenet of retinoblastoma treatment is something called intra-arterial chemotherapy. So this is an interventional procedure. So our interventional radiology friends do this, and they thread a catheter or a small tube from the femoral artery in the thigh of the baby up through the body, up through the carotid artery, towards, but not into, basically at the area which the ophthalmic artery comes off and feeds the eye, and they pulse chemotherapy into the eye. So you're able to give, half a teaspoon of chemotherapy directly to the eye. It's a very successful treatment. We use it primarily for children that have disease only in one eye, or for patients who have had a recurrence after they've had systemic chemotherapy. Okay. And most of the risks regarding intraarterial relate to the procedural risks. And to be honest, some parents don't want it. And that's another reason why we sometimes use systemic. So the children do have to go to sleep again. So it's another anesthesia. It is again, a procedure to put the chemotherapy into the eye. And there is some vascular risk related to the procedure for the eye, the retina, and even the brain, although that's quite rare.
What about, do they still do radiotherapy, like plaque
radiotherapy? I know radiation used to be a much bigger tenet of treatment, and it could either be given as external beam radiation therapy or as a plaque. It's really infrequent now. So external beam is almost never done. Thankfully, we have other treatments. When I was a fellow, it was still being done, but usually for seeding. So seeding is when the main tumor in the retina is doing well, let's say, but the tumor has broken off and is now floating around the eye. We now have intravitreal injection of chemotherapy, and so we can avoid radiation in that setting. I've done a handful of plaques for retinoblastoma, so plaque brachytherapy, usually for a retinal recurrence. But again, pretty rare. We don't need to that often.
Okay, so that's another thing. So
it's a big step forward. The radiation, especially the external beam,
it's disfiguring.
It can be disfiguring. The eyes are very dry. You cause cataract in a patient who has germline retinoblastoma, meaning they have that mutation in their body. They're predisposed for second cancers around the eye, and you've increased that predisposition. So we like to avoid radiation whenever possible. And again, thankfully, it's not done that frequently.
Okay, so then the thing I think that most parents are worried about is enucleation. When do you still need to take the eye out?
So primary enucleation means you do that up front. Secondary enucleation means you do it after therapy. I present enucleation as a therapeutic option to 100% of my parents. I think it's really important. There are kids, even in the United States, who die of retinoblastoma, which is really heartbreaking to me. And so many of those parents, when I have interacted with them, say to me, no one ever told me that removing the eye was even an option.
What, really?
And I think that's heartbreaking. So in the same way, I present the whole gamut of treatments, and I say, if this were my child, I would be leaning here. But people have to weigh all sorts of things. I have patients who come to me from Hawaii. They might not want to fly every month for 3 years to see me. I have patients who drive hours and hours and hours. There's one parent only. They know their home situation and their social situation best. So I still have families in 2025 who say to me, you can do a 1-hour surgery, you can remove the cancer, which is removing the eye, and my child's other eye is normal, and then we're done.
And that's
And most of the time you're done. A small percentage still need chemotherapy after, but most of the time they are done. And frankly, many of those families are really happy.
Yeah.
Okay. It's obviously, you wouldn't do that treatment up front for a child that has bilateral disease, usually, because usually you're fighting to save both eyes and save any kind of useful vision, which is why the discussion can be quite different. And then I tell my families also that whatever decision is made today, unless it's enucleation, a different decision can be made tomorrow, right? So let's say we do intraarterial chemotherapy and there's not a great response, or they have bronchospasm or some other complication related to the procedure. Well, we can go to systemic and vice versa. And if the eye isn't responding to either of those, my job at the end of the day is not actually to save the eye or the vision. That's the cherry on top.
Yes.
My job is to save their child's life. And so if the cancer is not responding, the eye has to be enucleated. And again, I talk about that from the very beginning so that they hear that term, they know that, and they know it's a possibility. And I've had kids who've had recurrences and parents want to try another therapy. If it's safe to do so, we do that. And I've had parents who say, I want to be done with this.
Do you worry more, or I guess really statistically, survival rates? How do they look if the parents choose to not do enucleation, to do some of these?
These are great questions. The risk, again, in the United States, so
Yes,
in Europe, in the United States, we're so lucky. I have had a handful of kids in my now almost 15 years of practice that have presented with cancer outside the eye. By and large, here we are blessed that the kids present with cancer inside the eye. Once the cancer is outside the eye, the risk of death of that child unfortunately goes way up, and it's much, much more difficult to treat and requires much more intensive therapy, including usually radiation. Okay, so these are two different beasts, honestly, inside the eye and outside the eye. Thankfully for the kids that are inside the eye, I mean, the chance that they are going to survive this cancer and live is 98, 99%. So it's very good. Generally, not always, but generally patients who unfortunately do develop metastatic disease have had really prolonged treatment. So like really prolonged efforts to save an eye where the tumor is not responding. And I suppose services, meaning retinoblastoma services that push that, probably save more eyes.
Right.
But in my hands and our service, we really focus on if the tumor is not responding and an eye is unlikely to see well, we call it.
Yes.
So we think that's important.
I mean, talk about for parents that choose that option, whether primarily or secondarily, because their cancer is not responding. I mean, there are really great options prosthetic wise.
Yeah.
You know, and I think that there's always that fear as a parent. First, we want our child to be healthy and we want to protect their life, of course, but then we don't want them to ever feel ostracized or get bullied.
That's right.
And I see these kids in my clinic and they look fantastic.
They look fantastic.
I actually would send them again to California because there was this fantastic ocularist in Beverly Hills that just did such a good job. But
that's 100% correct. So the patients do really well, you know, especially for these little kids. They're not seeing out of this eye, right? And let's talk about kids that have unilateral disease. It makes it a little easier. So one eye has cancer, other eye's normal. They're not seeing out of this eye. And so if it's safe to try to save it, that's fine. If it's really advanced, this is honestly often the best option for many of these families. And they're really happy to have their kid cured of cancer. I mean, I'll tell you, there's lots of cancers where the families are not talking about that. And so it's a blessing to have a healthy child cured of cancer. That's an amazing thing, and that makes me happy. The prosthetics or the fake eyes look really great. In fact, now after enucleation, we even put in a temporary prosthesis right away. Look, it's not perfect right away, but it's better than it was before when it was clear. And once they get their permanent in, it looks very good. There's usually some movement. It's painted to be the color of the other eye. By and large, it's very good. So again, saving eyes is something that I love to do and it makes me very happy, but I am always mindful that my number one job is to save a life.
And that's really what I think, the way that you talk about it with the parents from the beginning. Yeah. It's such an important discussion. What do you tell them about the follow-up? Let's say they preserve the vision and they're going intraarterial chemo.
Yeah. That's a great question.
About follow-up?
So I talk about this as well because sometimes this actually impacts their decision ultimately. But if we are saving an eye, I need to make sure that eye is responding to treatment. And so generally for the first year after diagnosis, I'm seeing these children every month under anesthesia. Year 2, it's about every 2 months. Year 3, it's about every 3 months. And so this is a prolonged time. You know, there are about 200 new cases of retinoblastoma a year in the United States. In my service, I see somewhere between 25 and 30. but I do about 500 retinoblastoma surgeries a year, right? Because one kid, I have to keep seeing them.
Yes.
And so this is really a long-term follow-up and a long-term commitment to care. And I think it's important that the families understand that.
What's one last thing as we wrap up that you would want parents to know if they don't have access to someone of your expertise in their community? Well, first, they can travel anywhere. And I do recommend for something like this.
Yeah. So I would say if the families have the means to do so, travel to a service where they see retinoblastoma a lot, because it's a rare disease, right? So it's rare. There are not specialists in every center. There are not even specialists in every state. And if you have the means to do so, going to one of the centers that does a lot of retinoblastoma treatment, I think is a good thing. It's what I would do if, knock on wood, my child ever had retinoblastoma. I think that's important. Those are also the centers that are more likely to be involved in clinical trials, research trials. We took our liquid biopsy work from research into clinical testing because we had a big service and we had so many parents who were so awesome and were very happy to let us test this fluid back when it was still under research protocol. So that's been really, really exciting. So anyways, big services with a local expert, I think, are good. Unfortunately, not everyone can do that and not everyone can access that. So there are, in this day and age, a lot of resources online. The World Eye Cancer Hope, which is weseehope.org, is a group for families and survivors of retinoblastoma. It is run by families and survivors themselves, right? And they put out a lot of really good educational content for retinoblastoma. They do family days in various states, and they can help connect providers. And most people, including me, can do online sort of second opinion educational type visits to help people as well. The rare cancer community is a small community, and we all tend to like to help each other. And, ultimately we're in it for the kids and we want the kids to do well. So
I think people might not even realize how much, just in general, people talk to each other. Doctors talk to each other.
That's right.
If I have a kid, I've texted you.
Yep.
I'm not sure what to do with this child. And I am very willing to recognize this has been 20 years since I've treated this actively. I'm not an expert the way I maybe would have been if I'd stayed in Boston. So let's find you someone that is, and let's at least preliminary. And so,
no, I think that's right. And, I sometimes will even say to my parents, hey, I'm going to share this picture. It's not going to have your any information about your child, but we're going to share this picture. We get consent to share the pictures. And that can help guide things a lot. Like I said, with the liquid biopsy, we're getting a lot of outside tests. So I know that outside providers have some of the same questions we do. And that's been able to help identify, is this eye still active? Is the tumor dead? Is more treatment needed? And, I also tell my parents that there are doctors like you who have skill and expertise and mastery in many diseases. I have skill and expertise and mastery in about 2, maybe 3 if you stretch. So I'm really good at retinoblastoma because that's nearly all I do, right? Yes. I do retinoblastoma, I do adult melanoma, I do some cancers in between, and that's mainly it. And so there's good and bad about being that subspecialized.
Well, I love it because that's what makes you so great in what you do.
Wow.
And pioneering in developing all these new technologies, new treatments, new ways of diagnosing retinoblastoma early.
Well, I love it. I love taking care of these kids. I tell my own kids about these kids, and they always say they're going to grow up and take care of the baby's eyes as well. It's so rewarding to be able to see these kids go through cancer treatment, grow up, thrive. The parents always want to know, can my kid drive? Is my kid going to be able to go to prom? Is my kid going to be able to go to college? Like all of these really big questions that you're facing when, one, you have a brand new baby. 2, half these parents didn't even know cancer in the eye existed, right? I mean, that in and of itself is a shock. And then they're thinking about the whole life of their child in front of them. So I like being with the parents and working with them through this journey and being part of their kids' lives. It's such an honor, actually, when families choose to let me take care of their children.
It really is an honor to take care of children and with their vision. This is something
that's right.
That's just so important, and
Yep.
to be able to help them and reassure them.
Yep.
And to make sure they reach all of those milestones.
Yep. It's a journey, and you see these little tiny things. They grow. I tell all of my families that they're my third baby. I have two of my own babies. This is how I don't have a third baby, because I get to
I say that too.
I get to hold and squeeze and love on them.
I totally say that.
Yeah. And it's
I would have had a
wonderful.
fourth then.
Yes. They're your fourth baby. But no, it's I think some families know, but I'm not sure all families know, like, how honored we as doctors feel to be part of their lives, to be part of the caring for their children, to intervene in these really critical moments in their life. But yeah, it's a passion and a real honor for us.
Thank you, Jessie, so much for joining me today. I know that you have helped just educate and hopefully reduce the anxiety for a lot of parents who might be facing this diagnosis or might be concerned because they see that white reflex in a photograph. Where can people find out a little bit more information about what you're talking about online or in person?
Yeah, so I think a couple of online resources that are great. I try to educate on my Instagram site, which is ModaMD. I need to do a little bit more education, and we'll be posting this podcast for sure. World Eye Cancer Hope, which is weseehope.org. Know the Glow. If you Google Know the Glow, that will come up as well. And then each hospital generally has some educational information about the diseases that are there. So our hospital website also has some fantastic content about retinoblastoma, which me and my medical oncology colleague have written together.
Thank you, Jessie. I appreciate you being here.
Thank you.
Thanks for joining me on In Focus. If you found today's episode helpful, I'd love for you to share it with a friend, leave a review, or hit that subscribe button so you never miss an episode. For more tips on eye health, parenting, and staying focused in a busy world, follow me on Instagram at Dr. Rupa Wong, or head to drrupawong.com. Until next time, keep your vision clear, your priorities focused, and your family thriving.